All right, welcome back to Medical Mondays, everybody. The doctor is in the house. As we discussed at the top of this show, we are talking about pain management, and Dr. Madhu Yelameli is here from the Nashville Pain Center. So good to have you here. Thanks for coming in. We appreciate it.
Thank you.
615-737+ is the phone number if you would like to call in. We've got a number of things that we do want to discuss with you. You know, when it comes to, I just went over a couple of the myths, and one of the first things, and the things that we read in the news all the time about dealing with patients who have pain. One of the ways to deal with it is through medications.
Correct. Yes.
Opioid, narcotic pain meds. There are other anti-inflammatory medications you can use that aren't not a narcotic, right?
Correct.
But the issue is that, you know, there is a level of abuse with some of them. We hear about pharmacies being robbed all the time, people who are addicted. And I know that the Drug Enforcement Agency and officials have really tried to crack down and make this tougher for abuse, right?
Yes, it's much tougher nowadays than it was like about a year or two ago.
Right.
It's much tougher for people to abuse these drugs.
Right. But so if a patient comes in and you know has chronic back pain and says, "Look, you know, just give me some hydrocodone, Vicodin brand name or whatever, you know, can I just have some painkillers to help out?" It's not that easy. You can't just say, "Well, yeah, here you go, you're in pain."
Not at all, because when we see a new patient now, it takes me almost an hour to evaluate a patient. We have to look at their entire history, medical history, pain history, and we have to put them through a thorough physical examination and look at all their investigations like MRIs or X-rays and see exactly where the pain is coming from. And first of all, convince ourselves as doctors that yes, this patient seems to be in some pain, real pain, and there seems to be some objective evidence to the pain. It's not just a patient walks in and says he has pain and you write a script.
Right.
No. And once we also know that the patient has a good history behind, like has not abused alcohol or not abused other drugs in the past, and we look at the previous clinic notes if they have come from some other clinic before, and we look at all those things, and we have a way of risk stratification. You know, we're stratifying the risk of that particular patient.
Right.
And we say, okay, this patient is a low risk for opioid abuse, or moderate risk, or high risk.
Right.
And there may be a patient who is a low risk and has plenty of objective evidence of pain, and let's say the bone-on-bone knee arthritis, not able to get a surgery done for that, or severe spondylosis in the lower back and severe spondylosis in the neck. Of course, this patient needs some kind of help.
Yeah.
Maybe non-opioid medications they might have already tried and they might not have helped the patient.
Right.
So you may have to put these patients on some kind of a stronger medication like an opioid.
Right.
What if the similar situation happens, but the patient also has a drug addiction problem? What do you do then?
Yeah.
So this patient,
you have to find another route then, right?
Or we just say he is a very high risk for opioid abuse and put him on a much closer monitoring regimen, and we still treat them with narcotics, but using much closer supervision, monitoring.
So if they're calling back saying, "I want a refill right now," and then you're like, okay, something's going wrong here.
Yes.
Because you're monitoring. Right.
Right. So these patients get some kind of relief from the narcotics, but it's very, very important for them to stick to the same dose that the physician has prescribed, even if they're hurting more. Because some patients think that if they're hurting more, they have the right to take more. No, they don't.
No.
So this has to be, the patients need to be educated a lot.
Yeah.
And so many of the patients are innocent. They don't know that they're getting addicted.
Right, and that can happen, not just physically, but emotionally. Also,
they do get addicted once. After, like, it can happen after 6 years. It can happen after 6 months of being on opioids. So patients have to be very careful. They always think that I don't have to follow these rules because I have real pain.
Not gonna, and it's not going to happen to me. I'm not going to get hooked on.
So I'm not one of those drug addicts on the street. No, we're not saying you're one of the drug addicts on the street. You're not intentionally abusing drugs. But unintentional addiction is as common as intentionally.
Has it made it more difficult, though, for, you know, we hear about, you know, people who have cancer and really serious, they obviously, to improve their quality of life, some of these
Yes.
medications, like your OxyContin, which we hear cancer patients with timed release,
Right, right.
that really do improve. But is it making it harder for them to be able to receive the medicine they need?
Actually, not really. I mean, if a patient has severe end-stage, cancer disease, there is really no problem in getting these medications. It is, they have arranged it
To
in
just
such
make
a way.
them comfortable
Yes,
and as
there is-
pain-free as possible.
No,
and, right.
there is no problem with that as of now. Yep.
All right, and we want to get into something I mentioned before, which we're going to be talking about. We're going to take a few phone calls first, and that is the PRP, or platelet-rich plasma.
Yes.
This is really a kind of a next generation
Correct.
of,
Yes.
of
it's-
treating different problems with pain, right?
Right. Now, we have come to a stage where, let's say, a patient has knee osteoarthritis of the knee, let's say simple arthritis of the knee. What we do now is that he gets some steroid injections.
Right.
They get some relief. A few years go by, they get some relief, and then it stops working. Or you may have to do the steroid injections more often
Right.
to get the same relief, which is not good. Then we have other hyaluronic acid injections and other things we have that we can use, but sometimes they are also not very useful in a patient who has moderate to severe arthritis of the knees.
Right.
Now, next thing is surgery. So mostly they go to the orthopedic surgeons, and this orthopedic surgeon say, okay, you have tried everything and you're old enough to get a knee replacement, above 50, 55 years, it's okay, now we can do it. But the patient may not want to have a knee replacement. Or the surgeon may not want to do a knee replacement because the patient is too young, or the arthritis is just mild to moderate.
Right,
They may
right.
not do it. So what do you do in these cases? So we have to come up with something new. And the scientific medical community has already come up with these options. So what happens with platelet injections is, platelets are a part of the blood and blood cells. So they are, when there is a wound, when there is an injury to the skin, let us say, blood comes out and the platelets clot and stop the bleeding.
Right.
After that, they start secreting some growth factors. So these growth factors actually stimulate formation of new tissue, and that's how healing happens. In any other injury, that's how
Right.
healing happens, because of these platelets secreting growth factors. Now, so what we are doing now is getting these platelets out of the blood. We just withdraw some blood from the patient's own body, and then we separate the platelets
Separate the
out
platelets.
and inject it into the knee. These platelets may stimulate some growth. It won't be like day and night,
Yeah,
it's not like you
miraculous
take
the
an
next
MRI
day.
and next and
Yeah.
everything looks like a 30-year-old's. No, but it may cause some healing to take place in some small cracks and crevices inside the knee, and may help in decreasing the pain and help the patient be a little bit more active, and maybe prolong maybe wait a little longer for the surgery. So these are some of the things that platelets can do.
Wow. All right, we're going to talk more about that. We want to get to a couple phone calls.
Sure.
Ready to take some? Let's go to Teresa on line 1. Hi, Teresa. Welcome.
Hi.
How are you?
Pretty good, I guess.
Okay. What's on your mind, Teresa? Go ahead.
Okay, I have a 2C, a 4C, a 5C, and a 6C messed up my neck. I have chronic neck pain 24/7.
Wow.
I have spurs on me. I have been referred to a pain clinic, but I know nothing about what you do there.
Yes.
And, I mean, I've been on pain medicine, but I don't want to be, like, hooked on it.
Correct.
But when I hurt so bad, I have messed my esophagus up because I've taken like 10 or 15 Tylenols, ibuprofen
Oh my
a
God.
day to get through the pain. And then when I do get to the doctor, I get pain medicine, but I don't. I don't want to get hooked on it where I'm a drug addict or something.
Right.
You understand what I'm trying to say?
Correct,
But
correct.
I hurt all the time. And this one bone doctor, surgeon, wanted to put 2 rods and 8 pins in my neck, and that ain't going to happen. Because I'm
Okay.
terrified of that
You're
surgery.
terrified of the surgery. Okay, so number one, you want to know about options for just managing the pain and then perhaps some treatment
Right.
to
Yeah.
resolve this, right?
Yeah, because I'm in pain all the time,
Yeah.
and then I have arthritis on top of that, and osteoporosis.
Sure.
It's a very common problem, Teresa, that you're having. So when you have this arthritis and bone spurs in your neck, a part of the pain in the neck will be coming probably from your arthritis. There are little joints in the neck that join together these little vertebrae, we call them, and they can get arthritic. And arthritis in the neck can cause a lot of pain, and it can even shoot towards your shoulders and go up your head and cause headache.
Yes, I get that.
Right.
Yeah.
And sometimes the neck pain can also shoot down your arms and go down to your fingers and cause numbness and tingling in the hands. And this is mainly because of
bad.
and then if that happens, that means you have some pinched nerves in the neck. Now,
I have a sciatic nerve on the left side.
right.
Yeah. Okay.
So what we can do for this is there are certain procedures that pain specialists do to help you with these pains. It's not just the medications. But when we do some procedures and also injection procedures and use some non-narcotic medications also along with the regular opioid medications, you will get better relief. When you get better relief, you will not be hooked on to any drug because you won't be taking too many of those because your pain is
Right.
already controlled.
Yeah.
So it is what happens in some cases is that if the patient is not offered injections or if the patient does not want to do injections, then you will have to just rely on narcotics all the time.
Yeah. So you've got to
you-
take some other step.
Right. So if you keep taking narcotics for these pains, of course you will get hooked onto it because at one point we call it tolerance when the medicine will not work at the same
Yes.
dose that it was
And you
working
want-
before.
yeah,
you
yeah.
want more, higher dose, higher and higher doses. And then
And that's what you don't want to get to.
yes, and then you get dependent. That's the second stage. And the third stage is addiction, which can also happen in some certain percentage of people.
Right.
So when we do a multi-modality management, when we do some injection procedures, when we also use non-narcotic medications, and also probably send you for some physical therapy when your pain is under control, with all these modalities put together, your dependence on narcotics will be less. So that is how we manage pain in pain centers like mine.
Okay.
Teresa, I would, at very least, follow your general doctor's, advice and see a pain specialist, or maybe go see Nashville Pain Center and at least get a
Correct.
consult
Yes.
with them.
Yes. Certainly.
I'm listening to y'all all the time, so.
And they
you know,
won't
I'm
they won't put any rods
Yes.
in your neck on the first visit anyway.
Right.
I understand your fear for
well,
that.
this one doctor, he is literally terrified me.
Okay.
So
Yeah, I understand. Well, that's understandable, but
I'm killing myself.
it's a quality of life issue too. I
Right.
mean, it's really difficult for
Yes.
I mean, I've literally had to go to the ER.
you. Oh
My
gosh.
esophagus is eat up from taking 10 to 12 ibuprofens,
Because of
and
the-
then on
yeah.
top of that, 8 or 10 extra strength Tylenols
Wow.
a
Yeah, that's
day.
just too much.
That's more dangerous than
And more dangerous for
some
your
of the
liver too,
opioids,
right?
Liver and
Oh, I
kidneys
know.
and stomach.
They've checked my liver numerous
Yeah.
times. Thank God my liver's fine.
Okay.
Okay.
But it's just the pain, and this
Sure.
chronic pain in my neck, and the 2C, the 4, 5, and 6C.
Yes.
They say that needs surgery.
Right. We can take a look at the MRI and give you the right directions and which way to proceed.
Teresa, thank you and good luck. We've got some other calls we want to get to here, but we really hope you're feeling better. Let's go to Betty next on line 2. Hi, Betty. Thanks for holding.
Thank you for taking my call.
Sure. Go ahead.
I have had shingles now for 4 years. They've gone internal now, and I was taking gabapentin, but it doesn't help. I need something.
Where exactly is the shingles? Which part of the body is it affecting?
It's from my belly button all the way up to my bra in the back.
Okay.
Right.
So mostly this is where most commonly in the shingles attacks, these nerves that run along the ribs, they tend to stay there dormantly.
This is the chickenpox virus that we
chickenpox
hear so much
virus,
about.
and suddenly
It's-
when your immunity is low, it acts
just-
up and
right.
causes pain. You said you have this for the past 4 years?
Is that right, Betty?
Pardon me?
How long have you had the shingles?
4 years. They've gone internal now.
Okay.
I had them on the outside. Now
Right.
they're inside.
Right. So you don't have the rashes anymore. You had the rashes about 4 years ago, but the pain never went away after the rashes
No,
disappeared?
sir, it's there. It's like I've got a curling iron laying on my stomach right now.
Okay.
So that's called post-herpetic neuralgia, we call it. It's a very serious condition, pain condition.
Right.
It's an extremely painful disorder, one of the most difficult pains to actually treat. But there are lots of ways we can treat that. We are quite well versed in some of the procedures we do for this.
Yeah.
We start off with blocking the nerves that run along the ribs, and that itself can give a good amount of pain relief. Sometimes we perform radio frequency ablation of these nerves. We can do some epidurals in the thoracic spine and see if that takes care of this pain. There are other medications we can use. Gabapentin, if it is not helping, maybe you have not tried the right dose. Maybe we can go up on the dose to the highest level. If that doesn't help, there are other medications called pregabalin, which is much more potent than gabapentin. And these are not controlled drugs. Of course, Lyrica, that pregabalin is a scheduled drug now.
We
But
see a lot of commercials for
yes,
Lyrica and others right now. Yeah.
It is a controlled drug. It's sort of a scheduled drug now. It's
Right.
scheduled 4 or 5. So there are drugs like that we can use, and we can use some topical creams that have that contain real drugs that you take by mouth, that we can compound it in the form of a cream and try those on the skin and to see if that takes care of the pain. And we even do spinal cord stimulation for this. That is a very effective way of treating post-herpetic neuralgia pain, where we place electrical electrodes on the spinal cord and stimulate the spinal cord, so the brain only feels the vibrations from the stimulator and blocks the pain impulses at the level of the spinal cord. So this is another very advanced treatment for this. We may not have to go all the way to a spinal cord stimulator.
Right.
We may be able to manage this pain with just a bunch of medications.
Again, you're talking about multimodal, as you mentioned before, just
Correct.
different approaches.
Right. We use a little bit of everything.
A little bit of everything,
and try to get the pain under control. And certainly it can be treated, but if you haven't ever had any pain treatment for this condition, you should try some pain management.
Betty, thank you and good luck. And we've got a couple of other callers on hold and some open lines at 737+. Callers are on hold. Be patient. We're going to take a quick business break here. We'll be back with more Medical Mondays right after this.